I'm going to turn it over to the two of you to start this conversation. So Cece, if you want to take over, and when Dr. Doddamani joins us, he'll join you on stage.
Wonderful. Thank you, Jeff, for that. Good morning, everyone. Great to see such a wonderful crowd for the opening session. Indeed, I think that Jeff's comments about definition of value in healthcare is in some respects where we are still a little bit stuck when you think about it. So even though we're all on a quest for value in healthcare, it certainly means different things to different individuals and stakeholders across the industry. And I'm looking forward to our opportunity to chat a little bit here today about a couple of very important perspectives and stakeholders in that process. But also, we really wanted to share with all of you that we would love for this to be an interactive session. Shantanu and I were laughing this morning that we sort of both agreed to come and do this as long as we didn't have to do any slides. So you're getting no slides from us, and we may even make you do a little working and get up to some microphones and holler out some questions and comments to keep this really interactive. The other thing is, I happen to know that Shantanu and I are both on Twitter, so you can go ahead and tweet about how amazingly great and wonderful and articulate, and that's everything that we are too, and we'll love that as well. So we are expecting Sanjay to join us just in a little while. We got word he was on his way.
A few more minutes and I'll be answering for CMMI as well. I'm
there you go.
Very comfortable with that.
Exactly. But this does give us an opportunity to just talk a little bit about Shantanu and especially NQF. People here might have a sense that they know or have known NQF for a long time, but maybe bring us a little up to date on NQF and sort of your lens on the value conversation and the push toward value.
Sure, thanks, Cece. And I want to thank you all for being here and thank the organizers for having me here. So NQF, so in the vein of interactiveness, I do sometimes like to start my talks with a question for the audience. And it requires a little bit of bravery on your part. How many of you have never heard of NQF or don't really feel like you know what we do? So just raise a hand.
It's fine.
All right, see, this is a highly honest audience. Other audiences, you don't see any hands, and I know that they're lying. That's great. So we are a nonprofit based here in DC. We're in our 20th year now, and we were actually founded out of a Clinton administration report that was really focused on patient protection in healthcare. So this was back in the late 90s. The Institute of Medicine report To Err is Human had just published, really capturing a lot of public attention on the problems of quality and safety, particularly in hospital settings. And there was then this committee that got started. I had just offered to start answering questions for CMMI.
Perfect. Save me to it.
So there was a Clinton administration committee that got launched as a result of all of that work that was focused on patient protection, and one of the recommendations was the creation of a private entity that would bring more scientific rigor and consensus to quality measurement and improvement activities nationally, and that became the National Quality Forum. So that has been our mission from the very beginning. We have obviously, as the conversation around value has transitioned, our work has transitioned, but we do a few things just broadly speaking. First, we help to endorse measures, so that is essentially you can think of it as measure certification. So anyone can create a quality measure. We will run it through various standing committees that we have that are multi-stakeholder by design, so that will be doctors sitting next to patients, health plans, technical experts, et cetera. Those committees will review the measures against criteria that we've established and recommend that measure for endorsement or not. Second, we conduct programs specifically for CMS to help them decide what measures should be included in their various programs. And again, we do that in a very multi-stakeholder, private sector-driven way. And third, we help to create resources for quality improvement that are also, again, very multi-stakeholder driven. So in all of this work, we've been asking, how do we transition the work to better meet the needs of today's sort of increasingly value-based environment, although not predominantly value-based environment, and would be happy to take any questions that you have or that you all have to talk more about that.
Great. Sanjay, welcome.
Good to be here.
And we were just getting started on even the fact that the definition of value in healthcare is kind of up for grabs. But maybe Jeff mentioned that you're a medical officer at CMMI. Maybe you could just start with a little bit of where CMMI fits into the value equation or discussion today, and what perspective you're bringing to that effort.
Happy to do so, and good morning. I'm so sorry that I got here a few minutes late. But what I wanted to firstly say is I'm so delighted to be here and actually on this dais with the two of you, because this is really that incredible equation between innovation, quality, and overall value-based care. And when you look at where CMMI fits into the broader scheme, you really think of it being the tip of the spear in value-based care. The initiatives, especially over the last couple of years, have been very accelerated to aligning itself with the mission and the strategic initiatives set out by Administrator Varma in CMS, including the reduction of burden and paperwork. And so you will see a much more leveraged approach with regards to innovation in some of the models that have come out. No surprise in direct contracting, in some of the kidney care specialty initiatives. There is really a much more parsimonious approach to quality, as well as a sort of a decluttered environment for physicians to have greater eye on how to approach value-based care with regards to having streamlined payments to be able to perform clinical functions, and really to incorporate things that were previously not possible, such as social determinants of health. And so when we look across the spectrum of models, really moving from sort of bundles to episodes, from outcomes to longitudinal care, you really see this transformation that aligns very well. And it's in the context of a broader milieu of activities that HHS has really launched across the board, including some of the recent announcements around safe harbor protection and other initiatives. So,
Great.
Great.
I do want to come back and dive a little bit deeper into some of the different models and what we're learning so far. But before that, I have to ask one of my pesky questions, which is, as I travel around the country and talk, especially to health systems, physician groups, et cetera, and say to them, okay, how much of your revenue is at risk? And I'm talking downside risk, because upside is not a risk, it's a bonus, okay? I love when people talk about their upside risk. And really, if you give them the truth serum, most in this country are responding with 5%. So why the heck is it taking so long?
So this is a very, very challenging question, because people have for so long been so accustomed to the status quo. And so when you look at certain states, for example, California, they've gotten very good at managing utilization, and yet the focus of a lot of the work that you see CMS is interested to push forward is equally on prevention, on patient choice. And so in that context, giving an opportunity to manage the book of business in terms of a spectrum of risk that allows people to enter on the shallow end with some opportunities for gain sharing, but really, ones where it's very quality focused, to the other end of the spectrum, where it is really gain sharing focused, with, clearly with some quality incorporated in it, I think gives you that broad perspective. And so it really is a question of where do physicians and provider groups feel most comfortable, and, is there a mechanism to allow for that continuous evolution? And it takes investments. And so we know from a number of experiences, including some of the work around MIPS, quality setting, that physicians had and provider groups had invested quite a lot into the interoperability, into meaningful use, into a focus on analytics and quality and care coordination and other requirements that really need to be made in order to be successful in value-based care.
Mm-hmm. What do you think, Shantanu?
Yeah, it's a great question. First, I worked for a capitated delivery model at one point, and so the first point I'd make is that there's heterogeneity in the marketplace, right? So I completely agree that overall it's really low, perhaps single-digit penetration of real downside risk. But then there are models where they've gone to the other end of the spectrum and have really even achieved capitation. So lots of examples in California, in Florida, and downstream of even Medicare Advantage plans. Mm-hmm. And I think the private payers have made progress here. I don't think it feels like we're nowhere near a tipping point because overall the averages are small and patients in general aren't feeling a difference. And I would argue that organizations that are really at financial risk, like self-insured employers, they're not really feeling a difference at all. That's why you see them experimenting with lots of different arrangements, like Walmart's announcement, I think just a week or 10 days ago, about essentially their high-quality network of care. I think there's a few things sort of stymieing activity. First is maybe the way we communicate about it. So in addition to not having clear definitions for what value truly is or whom we're trying to deliver value to, there has been a little bit of cognitive dissonance created over the last few years where we've said, and there have been these sort of announcements from HHS that like a huge percentage of payments are now tied to value or tied to quality, and it's well over 50%.
Right.
I think that's a really, on the one hand, it's a true statement. I'm not suggesting that they're not being honest about it. They are tying payments and there are reimbursement changes tied to performance on quality outcomes, but that's not the same thing as really marching towards significant value-based arrangements with downside risk, right? So I think there's just the way we communicate about it has tended to make the waters a little bit muddy. And I think second, there's been this real question about how quickly can we move, and moving quickly really requires, I think, more mandatory approaches than voluntary approaches. And there's been a lot of back and forth in the last few years about whether mandatory models would be the models of choice. I think if you're giving providers a choice about whether or not to move away from fee-for-service, they're going to be hard-pressed to make the call towards value, or you're going to see only the same systems over and over willing to do that.
Yeah, I often compare it to my journalism days, and if my editors at the Washington Post had said to me, your salary will now be based on your word count.
Right.
What do you think would happen to the stories? They would not necessarily be better, but they sure would be longer. And I think even if the most talented editor approached me and said, you know what, the shorter story would be a higher quality story, I'd be like, no, this is my income you're talking about right now. So I do think that we've unfortunately put most of the medical profession in this economic paradigm in which this is how you make a living today. So Shantanu, you raised the idea of maybe some mandatory approaches. Let's continue on that thought, and I also want to hear thinking on some of the models so far, which ones you like or where you'd head, and then I'll get to Sanjay.
Yeah, so first, it's interesting about the NQF. We engage, deeply on the measurement side, and I personally believe, and we certainly organizationally believe, that there is no transition to value but without being really clear about what the outcomes are and what the quality goals are that we are trying to achieve. If we are not clear about that, if we don't crystallize it, then the transition to value is really about lowering cost, which is not sufficient by itself, right? It really needs to be about often CMMI talks about preserving quality outcomes or improving them. I think our focus is really we need to get better because we see a lot of deficiencies that exist throughout the system today. So that is the primary leverage point that we get involved through, is really considering measures, trying to drive measures towards more outcome measures, more population-based measures. And there too, I think we see some evolution, but I'm here to be completely transparent. It's probably not sufficient. Our quality measures today are not where they ought to be as a community. And I think the ease with which we collect quality data and share it and try to make improvement is not easy either. So one thing, to come back to your question about various models, I do think we have a challenge in measuring the outcome of various models because we have not really, a lot of quality measure development is really sort of still stuck in a fee-for-service mindset. We still, I would argue, as a community, broadly, there's lots of great measure developers around the country, but a lot of them are still fundamentally tied to fee-for-service data, a lot of that claims data, and their mindset is very much focused on what do we need today in the environment that we have. I don't think we have enough measures that really account for bundles of payment, for shared savings models, and truly, trying to measure outcomes in a more capitated or all-in environment. So that's a true shortcoming today that I'm happy to talk more about and help to address. But I think without evolving measurement, and again, being clear on what the goals are, a lot of this will look like only cost reduction, and cost reduction is certainly very important, but that cannot be the only guiding principle for the activity.
Sanjay, would you agree, and do you think that the ultimate destination is capitation in most instances?
So to address the first point, I can't agree more with what Shantanu said. In fact, I talked to a number of ACOs and other entities that talk about value, and in the same sentence, the first thing they say is, we achieved a shared savings of, and I get that that's an important metric, but it is not the only metric. And in fact, it really calls to question then what are the right metrics for value-based care in terms of the outcomes. When you talk to some of the sophisticated primary care engines that have been very accustomed to this work, they use terms that are not necessarily the same as some of the other conventional practices. And so that approach to admits per thousand, or ED utilization, or days at home, or hospital-free days, and things like that are so important as you look at it from a patient lens. So I just wonder whether it's not only been, fee-for-service driven. Some of these metrics have also been very much tied to hospital activity. And so, as we step back and look at the broader milieu of healthcare delivery, we're going to see a need evolving in community-based measures that are going to be equally important.
Mm-hmm. And so on the kind of spectrum of models that you've seen or been working with right now, what's promising, and what are the sort of the CMMI priorities for the next 18 months or so?
Right now in the United States, although there's some geographic variation, primary care has really only represented about 5% of the entire healthcare spend. And so that's got to change. If we're going to see a big change, it's really going to be a reinvestment and a reinvigoration of primary care. And so hopefully that will go to 10 and 15% of the entire healthcare expenditure as a surrogate for prevention, as a surrogate for patient engagement, access, and a whole host of things that would have otherwise been relegated to emergency departments and hospitals. The other part to this, just to address your point about mandatory, that field for mandatory, unfortunately, is not very popular, as you know. And so what are some of the other levers? Instead of increasing the number of payments for procedures, because we're often asked, are we going to pay for, separate telemedicine? Are we going to pay for remote care? One of the beauties of developing some of the models like primary cares, or even some of the specialty models, and even the future of BPCI, is really around creating an infrastructure that allows for waivers more than payments. And so you're going to be able to then deliver the kind of care, value-based care, that you see is right for your patients without the hindrance from regulation.
So I love that you brought up the primary care point. I couldn't agree more. How do you think we move from 5 to 10 or 15%?
So we're already seeing this change occur, and I think that it's really about the path of least resistance. And so when you create a bottleneck through E&M encounters as opposed to covered lives, you really bring in patients who may or may not need to be seen, or may or may not need a doctor. They may just need a nurse visit. They just may need a blood pressure check. So it's redesigning the primary healthcare environment and then really focusing on how specialty engages. Does a specialist need to see every chest pain? No, but does the specialist need to empower the primary care team to be able to get to the right patients so that they create the right infrastructure and access? And so to do that, you need to develop networks, you need to develop an infrastructure. And so again, that really comes to some of the recent announcements and the recent proposed rules that you're going to hopefully see come into play.
And just
the coming
sticking
year.
with this notion for a minute with the two of you, so isn't it ultimately about dollar flow?
Yeah, I think you're absolutely right, Sanjay, and I agree it is. So if we're going to see more primary care practices sort of increase here, I think you've got to center dollars and decision-making around primary care and around essentially these outpatient groups, whether they're single disciplinary or multi-specialty, but which I think multi-specialty will probably ultimately win the day. But I think if they're not controlling the flow of dollars, if they're not really trying to decide what services are most appropriate and utilized, and then, as Sanjay said, creating networks around that and really identifying high-quality institutions and providers, then it will be very hard to get out of the current practices that we're in. So absolutely, I agree. Give them decision-making authority, and chances are they'll do the right thing. The other thing I would say, and again, I do want to bring it always back to that quality lens, while I believe certainly in empowering primary care, we also have a real paucity of meaningful outcome data for primary care. So as much as more dollars will flow there, we do have to ask ourselves, are we holding the right standards in place for these outpatient models? That's really critical to make sure, again, cost and quality are going hand in hand. Just as a really basic two areas of deficit today that from an outpatient quality standpoint, first, safety. So we understand safety, particularly in institutional or inpatient environments, pretty well. There's been 20 years of work focused on that. Much less work on the ambulatory side. So I think we've got to do a much better job characterizing what safety looks like and really capturing that. That is a foundational element, right, to any quality program. And second, there are issues that are really, I think, germane to the outpatient environment, like diagnostic accuracy, that have not been really fleshed out enough. And again, if we're going to put them in the center of both medical decision-making and utilization and cost decision-making, those are just two examples of things I think we need to shore up.
Can I add to that? Because I think it's important in this environment not to be alarmist to specialists. I myself am a specialist, and I'm sensitive to the importance of injecting the right infusion of specialists. We have density in urban environments and a tremendous, lack of resources in rural environments. And so how do specialists engage and are there metrics to allow for some of that work? The other thing that leads to, we're really very pleased to see efforts from the professional societies is on appropriateness use and appropriate use criteria and choosing wisely campaigns and other things that really help specialists to get away from the fee-for-service mentality as a culture to a culture of safety. And so as we go forward, we really will, even as a center, be focused on some of those activities. And that really takes off from where Shantanu started a few years ago in really helping to keep the focus on avoiding harm and creating an environment of safety through CMS.
Well, and I'm so glad you brought up appropriateness, which is, I've tried to change my language of late. I used to ask a lot about low value care, which still infuriates me. But I was having that conversation with Dr. Rich Isaacs from the Permanente Federation, and I said, well, I guess you guys don't have to worry about this much, right? And he said, well, not nearly as much as probably in your fee-for-service environment. But he said to me, but we are doing a lot of work on appropriateness and the instances when the case merits immediately getting to the absolute best specialist in a field, because you can see that. So we think a lot about all of the lower back pain that goes to surgery right away when it shouldn't. But he made, I think, a similar point that there are instances when you absolutely want to get that specialist intervention very quickly. Let's talk a little bit more about appropriateness and low-value care too, because there's still way too much of it. And how does that get incorporated into the discussion around value, measurement, quality, safety, et cetera? Shantanu?
Yeah, great question. So those topics are definitely top of mind for us. I'll just give you an example of, inappropriate or low value care, I think, is so commonplace that sometimes we miss it or it just becomes part of the almost practice pattern. And there was a great article I just point out from maybe a week ago in JAMA from Humana, Will Schrank, that again, I think tried to recharacterize how much are we paying nationally in essentially low value care or just low value operations. And that was sort of an updating from a Berwick article about a decade ago, but still very eye-opening numbers. So I'm an emergency medicine doc. I was in the ER one day and I had the chair of radiology. I'm not going to tell you where I practice because this will be imminently findable. I had the chair of radiology come up to me during the shift and he said that I needed to order more CAT scans. Because if I didn't order CAT scans, his people didn't have enough CAT scans to read. And it wasn't, oh, you're missing stuff, you need to order more CAT scans, or patients are walking out with undiagnosed issues, you need to order more CAT scans. It was a very blunt, you need to order more CAT scans so we have stuff to read and essentially bill for, obviously. That is how I think, and that was sort of an acceptable dialogue between colleagues, which I found repulsive. And I was actually at CMS at the time, I was like, I gotta note this down, this is a ridiculous conversation. So that is how I think endemic this kind of dialogue can be in healthcare. I'm not suggesting everybody does it, but it is sort of commonplace. And we think about, we actually have words in healthcare or in medicine for this kind of behavior. We call it a conservative practice pattern, right? Somebody orders a lot of CAT scans that are unnecessary. They're being conservative. We don't call it what it is, which is they're being wasteful. They're wasting resources, they're wasting a CAT scan machine, and they're potentially slowing down the care of people who actually need that CAT scan.
And increasing radiation exposure.
And all of that stuff, right? So
false positives.
Yeah, so we've got to, I think, call it what it is. We've got to be willing to do that. That's fundamental to creating behavior change and utilization change. On the same side, there clearly is a role for measurement. We've got to do, as an organization and ecosystem, better job at defining appropriateness measures, low value care measures, and actually getting them implemented. I think these will be very important. The further you move along the transition to value, getting closer to capitation, what I hear increasingly is systems, groups wanting these kinds of measures so that they know what to implement internally. So even if they're not beholden to a payer to report this data in order to get some reimbursement change, they want to know what good looks like so that they can implement it for the purposes of their own improvement efforts and really try to drive towards better utilization at lower costs so that they do better in these value-based models. So I think there's a lot of work there to be done. We don't have nearly enough appropriateness measures as just an example of how measurement needs to evolve.
The other thing I would add to that, just very quickly, is that there are decision support tools. And I think those decision support tools in the context of provider behaviors are going to be very important to insurers. And they're going to see how much deviation occurs. And that could potentially go back into the milieu of payments in terms of, just such as star ratings. So although, we as the largest insurer haven't implemented that in its fullest force, and certainly not in the context of this conversation, I just want to throw out there that those decision support tools are going to be, incredibly important to a care of the future. They can also be incorporated into some of the diagnostic work. You could literally have, the machine, pick up brain bleeds or other, things and move them to the top of the pile to have, an immediate read and things like that. So it's really this infusion of AI, machine learning, decision support tools that I think are going to be incredibly important. And the health system is evolving as we see it.
Right. We can keep on talking, but if anybody's got a great question or comment, there are 2 microphones, and you can feel free to head to them at any time. See, there's always someone who's just wants to get up. And please tell us who you are, if you don't mind.
Hi, I'm Zahid Bhatt with Metasolve. We do a lot of quality measurement work and implement quality and safety measures. So I have a comment and a question. So the comment is that I know it was mentioned that some of this low-value care is done consciously for economic gain, and certainly that happens. But a lot of it sort of happens in these gray areas where a physician is under a lot of stress of all sorts and is not able to make a black and white decision. And in those areas, typically they tend to do more than less, because generally incentives in many different ways are aligned more towards that. And so it's this sort of vague gray area which is very hard to measure and extract within the care. And one of the common reasons is mentioned, fear of lawsuits, and tort reform is not that hot anymore. And so the question is that off the table, or is it still part of the solution?
Do you mind if I start?
Please.
All right, so thanks for the question. Great seeing you again. I did not mean to imply, and if I did, that all of these low-value decisions are sort of conscious, purposeful, purely at sort of thinking about one's own financial incentive. That is not the case. You're absolutely right that there's a lot that is driven by the way we set up systems and gray zones, as you described. One example of that, again, I'm an ER doc. A couple of months ago, there was an Annals of Emergency Medicine article that found that the longer that you are working in a single shift, right, you're getting tired, overwhelmed, you've seen a lot of patients, there's lots of things that I think are building up. The more likely you are statistically at the end of your shift to admit somebody, potentially inappropriately, and perhaps just as concerning, to prescribe opioids, right? You do that much more likely at the end than you do at the beginning. So absolutely, this is a complicated set of factors that I think drive all kinds of utilization behaviors. I do think that is why we need to put in the right measures to actually understand what those behaviors look like, and then do this kind of research to help mitigate them, right? So there are perhaps some decisions that in the last hour of your shift, just in emergency medicine, maybe you should be running by a colleague to make sure that I am not just admitting this person in order to create a disposition decision instead of what might be medically right for them or the most appropriate. I'm not going to touch tort reform. So thank you for the question.
I'll touch tort reform. So a couple of things. One, and I completely agree with Shantanu's points. We're not up here to suggest that these are just a bunch of greedy, clinicians that are out to make a buck. They're unfortunately been put into this fee-for-service economic environment in which to operate. So we've got to help change the environment in a way that they're rewarded for doing the right thing at the right time, clearly. But I will say, with respect to tort reform, my impression from studying a number of the cases is that we're seeing some really encouraging alternatives out there in the country, what I like to call bright spots, where there's much more of an effort for, let's say, a physician and clinical team to have a very honest dialogue with a patient and family if there has been some sort of an error or a mistake. And some states have gotten very creative around finding these alternative paths, so it's not just lawsuits. So I think that's kind of a positive reason why that conversation has quieted down significantly. Another question.
Hi, good morning. Amanda McMillan from Christiana Care Health System and eBright Health ACO. A question I had for your respective areas is we're about ready to quadruple down on the use of telehealth services, video visits, and the like, just because we feel that it should be very helpful into our payment approach, most importantly, our patient care approach. And can you just share where you feel your respective areas are with respect to measurement of the value of telehealth services or virtual care, and then any type of reimbursement future state?
Sanjay, do you want to start?
Yeah, it's interesting because I've also worked in an environment clinically where there's been access to telemedicine. And so what I will say is it's really about the dosing, and you really need to understand these could be potentially investment heavy, resource heavy, and so you really want to select the right patient population. Some of the areas where we've had incredible success is in the areas of dermatology, ophthalmology, but also some evolving needs such as telepsychiatry in the emergency department, especially for critical access hospitals. And so the whole spectrum needs to be evaluated from text, voice, and video, and where you need to be dosing one over another and in what context. So I think it's really left to the clinical team to decide. And from my perspective, at least, and this is the personal perspective, is that the greater waiver opportunities we have in terms of taking away sort of an expectation for payment, as opposed to infusing this, because this is the right investment to make in a broader value-based dollars equation, you're probably going to be able to be much more successful in scaling.
Yeah, so I think the way you positioned it is exactly right. There are lots of different modalities for communicating with patients, all the way from the asynchronous text email to the synchronous video encounter. I think if we try to overlay a fee-for-service approach to that and say we're essentially going to pay for units of text messages and units of video, that is not going to work, right? The overlay has to be, we are going to empower you to do all of these things. We'll devise a payment model that works appropriately, that essentially allows you to communicate in the way that your patient needs or wants. So that I think is on the payment side. On the quality and measurement side, we are early days in understanding what good quality care looks like with all of these different virtual modalities. And we're very engaged as an organization in that question. So over a year ago, we sort of executed a specific telehealth project, really looking to evaluate how quality can be measured from an outcome standpoint in a telehealth environment, and to understand how that differs or not from the in-person clinical encounter. And if there's a top-line message from that is, yes, we need measures that are good for that, but also those measures don't necessarily have to look that different from the in-person encounter. In other words, it was the strong feeling of the committee that, in fact, what we want is a virtual care environment that simulates the in-person encounter, because that's what patients want. So let's not have quality or quality measurement drive a different understanding. So based on that work, we've done work even this year on telebehavioral health, to your point about telepsych. And we're looking to do more work in telesubstance use disorder or teletreatment for these kinds of issues. So I think there's a lot of really interesting work that's kind of compelling. And again, this is about bringing the right quality-based approaches forward, but also really what works, right? So what are some best practices? What are some innovations that various systems have implemented? I think we believe that tele approaches or virtual care approaches help to solve the access problem dramatically. And we see that even in our rural health work. That's definitely true. I think from a transparency, integrity standpoint, the data is still out on quality outcomes. So do they help to preserve or even improve quality outcomes? I don't know. But solving for access is in and of itself extremely important.
I'm so grateful for this question because it enables me to brag on some of our members, which I am going to do because I think I can offer a couple of great real-world examples.
Love that. Yeah.
So for instance, and we are so grateful that the administration is now permitting telehealth in the Medicare Advantage basic bid, because we are finally at that point where there's enough experience that you really can be solving a lot of access problems, for instance, some of these targets, but a couple of other examples in addition to all the ones you've heard. At Select Health, which is the plan with Intermountain, they have quantified the millions of dollars that they have saved in helicopter transport simply by not having to fly a patient from a remote area in Utah into Salt Lake where they have a particular specialist, because out in these remote areas, they can do the teleconnection link to the specialist right there in sort of a central hub in Salt Lake, guiding and advising. Often it's neonatal, by the way, but a number of areas. Presbyterian in New Mexico has been using telehealth in its Medicaid program. Presbyterian has never lost $1 on Medicaid. Think about that for a minute. Stop and think about that for a minute. They have been so innovative and so far ahead. Up in Martins Point, which is up in Maine, they use it, again, to connect provider to provider with a specialist, a world-renowned expert in Boston on certain cases. So it's not just simply, and then, I get on my device to talk to my KP clinician whenever the heck I feel like it, right? And it's fantastic. So there are the convenience pieces, there's access, especially for rural, although we're increasingly seeing in urban settings, patients that perhaps would have to take multiple buses and navigate downtown. The behavioral health one, I think, is a really promising area for certain individuals that maybe don't want to be walking into that building that says mental health clinic on the front door. So I completely agree. Now we're going to need the rigor to really assess what are the good quality legitimate uses, or we will have this flood of goofy stuff going on. But believe me, your children are crowdsourcing photos of their rashes on Instagram today, okay? So the technology is here, and certainly the mindset of millennials and others are, if I can get everything else on my phone, why can't I get my doctor on my phone? So I think it is incumbent upon this industry to kind of catch up quickly and then do it in a very responsible, rigorous scientific method. So there's my soapbox. Next question.
I'm Susan Huang. I'm from the Palo Alto Medical Foundation, part of Sutter Healthcare. I'm the Chief Value Medical Officer. So I agree with everything that you guys said. And in terms of accelerating this work, we talked a lot about metrics, and we want to work in lockstep with NQF, with CMS, with our external payers. It's almost like different levers working together, different gears. How do we accelerate the work so that we can define the metrics so that we're not going off on a tangent? We're trying to very systematically go through all our service lines, our geographies, and looking at those opportunities, but we want to be able to kind of align with CMS, with NQF, with
Shantanu, you want
others.
to take that?
Sure, yeah, so it's a great question. So I think there are some fundamental sort of elements of the quality enterprise that are still missing. One of them is just data, right? So when we look at measures that are coming into endorsement, and we will review, a couple of hundred measures a year, a lot of those measures are still based on claims data, and we just have to acknowledge there are some fundamental limits to what claims data are able to assess about a clinical interaction. And then we see a significant drop-off when you think about measures based on the electronic medical record or even registry-based measures. I think there's a lot of different data sources now that could inform the quality enterprise. They're certainly not seamless with each other. You are not able to see the same data point across these different across the data architecture. You're not able to see the same patient. I have a lot of concern that as much as registries have grown up in the last 5 to 10 years, we have probably 30 registries now around the country or more, they have essentially resegmented the patient according to clinical discipline, right? They are not integrated, they're not seeing the patient in totality. I think that needs to be solved for if we're going to accelerate the rate of good measure development. We need to see much more crosstalk between these different data sources and take advantage as appropriate of each data source. Again, as an example, we don't want endorsement to become a bottleneck for good measure development and getting it out into the field. So a few years ago, we created a trial program for electronic measures, right, essentially based off the health record. And we said, look, we will actually move more quickly to endorsement. We'll give you 3 years of provisional endorsement as long as you promise to come back in and let us assess the outcome of that in order to help further the development of these and use of these measures. We got very few measures. We basically only provisionally endorsed 10 maybe over the last 3 or 4 years. These are hard to develop measures. They're hard to test. And we're not seeing enough of them being put into use in order to really assess whether that provisional program is working or not. I think that has to fundamentally change if we want to really accelerate good measure development.
The other aspect to that, Shantanu, as you well know and recognize, is that you now are able to get a more continuous flow of data as opposed to periodic sampling that could be so at risk for error, and also a tremendous burden. I mean, think of the number of hospitals that need to hire nurses and other quality management staff to be able to just get to the data before it can be submitted, cleaned up, and submitted.
Before we run out of time, I do want to bring up the current hot topic, which is ironic because it's been around forever, but social determinants of health, and how that fits into the effort to drive toward value.
So, in a nutshell, as you well know, the actuarials of the Trust Fund for Medicare are deeply concerned that by 2026 we are really not going to be able to make the kinds of payments we make currently for healthcare. And when you look at countries that spend 70% on social determinants and 30% on healthcare, and what that costs, and what we spend 70% on healthcare and 30% on social determinants, and how that influences the high cost of care. And so we recognize, and I think it's a nationally urgent attention issue, that we need to be able to get out of the way and help to accommodate payments. And what better way to do that in a value-based care equation than payments that are as akin to Medicare Advantage, to capitation, that allows folks to be able to pay for and eliminate uniformity requirements such as an MA, to allow you to put into your bid those opportunities to manage social determinants, manage Medicaid, similar issues. And so I think as we go forward, and certainly as a center, we are very sensitive right now to the potential for models of the future to be able to incorporate social determinants.
Great. Shantanu.
Yeah, so it is definitely not new, right? So 20 years ago, the IOM said we had to address health equity and social determinants. And I just think as a community, we have not made very much progress on that at all, although we have definitely accumulated a lot of data to show the potential impact and the real need to do so. So I, again, agree with all of the levers that Sanjay has pointed out. I'm not sure that I can add anything new under the sun on this topic for you, because no doubt all of you have been talking and hearing about this, and the solutions are kind of in front of us, right? So we need better measures. We need to understand what really works in addressing social determinants. And I think as a sort of, we have to grapple with some fundamental questions. Are we going to use healthcare dollars to address these areas, sort of yes or no, or how significantly are we going to use those dollars? And two, do we feel comfortable then moving healthcare dollars to a non-traditional set of actors? Said another way, our provider's going to feel okay, our health plan's going to feel okay, not being at the center of the solution space for addressing social determinants of health. That's a huge business question for them, but I think if the only answer that we can come up with is no, the traditional healthcare model has to be preserved, they have to be in the center of it in order to allow dollars to flow, we'll be creating really inefficient answers for addressing these critical social areas. I think we've got to think non-traditionally, but that invokes a lot of political conversation inside the healthcare ecosystem. And you all know just as well as I do how challenging those conversations can be. But I think if we are not willing to take on those two questions and not answer them in the way that they need to be answered, this will not get addressed anytime quickly.
I'm going to take it through the lens of affordability. Recently, there was data to show that
Does that mean our time's
apologize
up?
for that. There was data to show that addition of a diabetes drug, an SGLT2 inhibitor, in systolic heart failure over and above the other three conventional medications that are used for systolic heart failure has an absolute risk reduction of 35%. If we want to pay for that, really mortality reducing and quality of life improving medication therapy, then we've got to be able to reduce costs elsewhere. And the only way to do that is not to deny services, it's to avoid the unnecessary utilization, waste, I think a whole host of things that we've discussed today. And so I think it's already answered itself that we've got to pay for food insecurity, medical transport, other things that are important to improve outcomes. And I think you can't do that without measurement.
With our time just about out, let me just ask you both very quickly to conclude for all the folks here who are interested in getting us to a value-based healthcare system sooner rather than later, what's one piece of advice they can walk out the door with today?
That is really hard. All right, you start.
So this is the penalty for coming in. Well, firstly, this is an exciting week. CMS, along with private payers and other stakeholders, came together under a convener to have a Learning and Action Network. So the LAN Summit is this Thursday in DC. And please go on the website. There will be announcements there. And as you may remember, the framework for risk in terms of quality and capitation really was laid out by the LAN. And so those 3 and 3B and 4 payments that really represent those APMs that we've discussed around downside risk and so on were really creations of there. And so thankfully it's not single digit, it's now double digit, but we need to be moving much further. And so you're going to have the release of data around where we are with over 70% of the country's payers.
Great.
So maybe my one request is forget who you represent. So forget that you might represent a health plan or a provider or whatever else in this environment. We are all fundamentally patients. And on the one hand, if you look at it from a patient perspective, capitation is at 100% because we all have limited resources in our wallet and our employers have limited resources in their budgets, right? So in addition to a lot of quality work, NQF is a small business. And I'm acutely aware of what we spend on our healthcare dollars every single year and the rate of inflation. That hits me every single year. It hits the bottom line. It affects how much I can take care of our employees. So if you just always have the mindset of you are a patient, these are limited dollars and we are all capitated, I think the solutions for value will bear themselves out. They will become much more apparent than if we stay within our various kind of professional roles.
Wonderful. Please join me in thanking Shantanu and Sanjay.
Thank you.
Thank you.